Okay, I will start the discussion for today with the same question, that if you have a patient on TPN, on total parenteral nutrition, now this patient is undergoing any surgery. Okay, so what would be the considerations if you are having that patient going for any surgery? You understand the
Regarding
question?
TPN, my anesthetic consent will be in preoperative, intraoperative, and postoperative. Also, in preoperative assessment, like other patient where we have followed the NPO, means proper, and but in TPN patients, it doesn't consider, because in TPN we can continue even the preoperative or intraoperative, and we have to also follow the order from the ICU at which date it was going, and we have to continue it intraoperative also, because sudden abrupt of TPN can cause hypoglycemia,
Okay.
and also some electrolyte disbalance. And but when we
Jamil, someone has rightly pointed out that this patient is automatically NPO, because this patient is, if the patient is on TPN, it means patient is usually 99% cases, patient is not taking anything. Okay, this is
yeah,
one thing. And actually the
that's I told,
concerns
that's I
related.
told that, sorry, that's I told already, that we no need to consider NPO this patient like in other patient, because this TPN definitely is the other route, no need any in the order. As told, as from different from the other patient, that we no need to consider about NPO time.
Yes.
I maybe
So
somebody missed it.
yes. So actually in the exam you have to be very specific. Okay, if a question is specific, the answer should be very specific, that the concerns would be here that because of discontinuation, okay, patient can go in hyperglycemia, sorry, hypoglycemia. Okay, so this is any electrolyte imbalance. Okay, and line related
care of lines of this TPN
concerns. Okay, so this is actually the question, and of course the other concerns, because usually this will be an ICU patient, so there will be concerns related to any infusions going on, careful shifting of the patient. Okay, so there will be specific procedures which we will be able. Okay, so today, yesterday we discussed about patient with hypertension optimization, asthma, COPD. Okay, and today I will ask some questions about thyroid. A patient with thyroid disease, what optimization, whether it will be hyperthyroid, okay, or it will be hypothyroid. Okay, so when will you say that the patient is optimized for hyperthyroid? Yes, you will be looking at T3, T4, TSH.
Yes, if no voluntary I will take, then patient should be clinically and
clinically
biochemically
and
should be
biochemically.
euthyroid. Yes,
So
and
clinical,
clinically,
what will you look at?
I will look about the heart rate, starting from the heart rate, and symptoms.
Whether patient is having atrial fibrillation or no, or
Atrial
any other
fibrillation.
symptoms
Yes.
of
Signs sweating,
hyperthyroidism.
yes, tremors, sign symptoms of hyperthyroidism. It could be
Pemberton sign. Is it a sign of hyperthyroidism or something else?
what? Sorry, sir, I could not catch you. What the
Pemberton sign?
It's a sign of retrosternal goiter. Assalamu alaikum, sir.
Walaikum assalam. Yes, it is sign of SVC, compression, superior vena cava syndrome, and retrosternal goiter. Okay. And also another sign which is there in thyroid patient is
tracheal compression.
exophthalmos.
eye signs.
Okay. So this is one thing. Then you will be looking at T3, T4, TSH. Which is most important?
THS.
No, TSH is more important in hypothyroidism. TSH is
No,
important. TSH is important, but here free T3. Or no? Don't agree.
always agreed with you.
No. Please correct me.
No,
Because
I think that the THS is giving the more mirror image that any disease is controlled or not, because if it's low, less than 0.5, that means automatically patients in hyperthyroid.
any other ideas, Memuna?
But
Would you like to say something on it? My plea is that TSH is more important for hypothyroid. Okay. And free T3 is more important for if you are suspecting thyroid crisis.
Yes, sir.
What do you think?
But do we need to have the documented biochemical normal profile for labeling it?
Yes.
I think so. Clinical criteria is more important than biochemical, or both.
But still we need
both are recommended, because
for
if we
elective surgery, because actually, this is a question being asked by our great philosophical examiner, proud for Pakistan, Dr. Arshad Taqi, for regarding level of TSH for hypothyroid. At what level would you like to proceed and what level you would not like to proceed? Okay, because level of TSH is definitely, if it is more, you will not proceed in hypothyroid patient. Okay, especially if you have if you have suspect any major surgery. Okay, so just reconfirm it. Maybe I'm confused, because my opinion is that free T3 will be more significant in case of thyroid crisis. Anyways, just reconfirm it. And how we optimize it? What are the different anti-thyroid drugs? Carbimazole and propylthiouracil. Okay, and propanolol. So the questions which they will ask, of course, we are just looking at this topic, but you should be revising the mechanism of action and side effects of any medication you are reading anywhere in during your anesthesia exam preparation. Okay, and for hypothyroid, the patient is taking thyroxine. Okay, so you don't have to omit even a single dose. When the patient is taking thyroxine, patient may become iatrogenic hyperthyroid. Okay. Okay, so what other things you would like to see, especially in hypothyroid and hyperthyroid, which may need optimization, like in hypothyroid, this patient is having hypertension. So control of hypertension is also important. Okay, and hypothyroidism, which may need to be optimized or regulated or expected, anticipated, is OSA. Okay, this patient might be at more risk of OSA. And hyperthyroid, we already discussed that the thing you should never miss is atrial fibrillation. Okay, what about pheochromocytoma? How to optimize this patient? What is the first thing to do?
We can start with alpha blockers, long
Alpha
acting,
blockers. And
phenylbuxin, and
what is that?
then
Phenoxybenzamine
phenoxybenzamine. What is that?
or prazosin?
Yes, or selective alpha blocker, prazosin, tazocin.
Okay, so what will be the sign? How will you say that the patient is now achieved alpha blockade?
Then is blood pressure less than 160,
No.
orthostatic hypertension,
Orthostatic
and
hypotension and nasal congestion.
and nasal congestion. Yes.
Okay, there is no blood pressure limit. I don't think so. Is there blood pressure limit as well? 160 by 100 you were saying? Yes, Jamil.
Actually, there is criteria that
Yes.
we control. There is some criteria that blood pressure should be less than 160.
Roizen criteria 1982.
What is that one?
Yes. A decrease of blood pressure, systolic pressure should be less than 160, and diastolic less than 90 over 48 hours before surgery.
Okay.
24
And,
hours.
24 to 48 hours.
Sustained for 24 hours.
Yes, that's what I actually, just a second.
Sustained.
Let me intervene. Let me intervene. Actually, the rise in blood pressure in pheochromocytoma is always episodic. Okay, paroxysmal. It's not continuous usually.
Yeah, episodic.
So that is the importance, that in 24 hours, that is the thing which is important. Okay, so alpha blockade, you say that when the patient has nasal congestion and blood pressure limit and orthostatic hypotension. Okay, then you say that the patient has achieved alpha blockade, and then you start beta blockade.
Yes. Hello.
Yes.
But the blood pressure should not fall below 80 over 40 millimeter of mercury, 45.
Why?
At least 15% from the baseline.
Yes, that
Because
is
if it is falling below.
Yeah, I will give you a hint. Remember one thing, that in the exam you don't need to reproduce each and every line of any criteria or anything written in the book. Try to stop or try to tell the things which are simple, easy to explain, because you will have no time to tell each and everything. Okay, so try to filter which is more important thing, so that you don't forget at least those one. Okay, so that is my message. Whatever you are telling is absolutely correct. And actually the people who say that they are asking more, actually this is not to fail. Believe me, remember one thing, in the exam, the failure or pass is not because of these small things. Any question. The main thing is that if you are safe, they will never fail you. I guarantee you. Okay, so this is my
Yes, and
point.
if you recall at that time, it creates a very negative image. So be simple, be relaxed, and be in a systematic way.
Yes. My message is that you don't try to overburden yourself by try to cramming each and everything. This is my message. Yes, maybe in something there will be all 5 things which they are expecting you to tell. Okay, but the basic message don't forget, because this fall in blood pressure you can complicate you, Mamuna. Because the thing is that this 20 to 25% is for acute control. Okay, in
Sorry,
chronic
sir,
management, sorry
sir, your voice just got disappeared.
Yes, I'm saying that in chronic patients, like in the chronic management, usually this is not the thing. Even if the blood pressure was 200 by 110, now gradually over the period of 4 to 6 weeks, you can manage the blood pressure even 120 by 80. You understand? Like gradually, or over the period of 4 to 6 weeks or 6 to 8 weeks. Okay, so that thing which my concept is, maybe if it is written somewhere, yes, maybe it is correct.
If you just say I'll try to maintain the blood pressure, it's also fine.
Yes, ECG, and for example, if there is any failure, okay, so you have to treat that one as well. Okay, maybe this patient is already on pulmonary edema, so maybe patient need diuretics. Patient may need digoxin for support of failure. or anything, AC inhibitors. Okay, because there is one main disease pathology we always discuss, but we don't discuss the end organ damage. So any optimization will be according to the situation. Patient may have some comorbidities. Okay, so this is what you have to see. And what will be the anticipation? Like, for example, in thyroid, crisis can occur. Here, myxedema in hypothyroid,
In hypothyroid, yes,
myxedema can
myxedema
occur.
coma.
And here, what can occur? Sudden bouts of blood pressure. Okay, so how will you anticipate for all three things? For example, if you think about thyroid crisis, what you will be doing? What will be the things which you should be doing? You will, of course, you will optimize the patient preoperatively. But if this patient, hyperthyroid patient, coming for emergency surgery, so what thing you can say? That I will be maintaining the depth of anesthesia. Okay, because stress response will be one of the factor to trigger any of the condition. Okay, so this is one thing. And then, of course, management will be airway, breathing, circulation, cooling maneuvers. Okay, then conversion,
IV beta blockers,
steroids,
yes.
potassium iodine. Okay, and then through NG you will start propyl thiuracil plus this carbimazole according to the condition. Okay, but it will not have. And cooling maneuvers will be all irrigation. Okay, cold saline, cold NG, cold Foley's, like passing cold fluids through. And would you like to give paracetamol or aspirin? Is there any problem with aspirin?
Aspirin is to be avoided.
We have to
Paracetamol
avoid
can
to
be
aspirin because it's increase the free thyroid.
Thyroid. Okay, so
Yes.
paracetamol can be given. And okay, so this is how steroid propranolol will also, and propyl thiuracil, which also will also prevent the conversion of peripheral conversion. And last, don't tell in the start, but dantrolene is also being used as a last resort in such condition. Okay, then the patient will be
Sir,
going.
hydration.
Sorry,
Hydration, sir.
hydration. Yes, hydration. Yes, you're right. Okay, so myxedema. What will IV thyroxine?
Yes, IV levothyroxine.
Airway, breathing, circulation. Never forget this thing. Okay, may patient might need IV thyroxine. Is there any role of caffeine also?
No, sir, never
I
read
think
about it.
not here. Maybe in post-operative apnea in pyloric stenosis, there might be now have a role of caffeine.
Anyways, reconfirm it, because aminophylline and caffeine, they also, if I'm not wrong, they stimulate diaphragm. At least aminophylline, I'm confirmed. For caffeine, you just recheck it. Okay?
Yes, sir, for symptomatic, yes. For symptomatic, you can say.
Yes. Okay, so myxedema will always be symptomatic. Am I right? And are you giving steroids as well in this patient, myxedema coma?
Yes.
Okay, so fluid management. Okay, so in similarly in both these just a second. In both these either thyroid crisis or myxedema coma, you have to anticipate and act accordingly. Both for both these conditions, post-operative HDU and stress factors and things like that. Okay.
Sir, I have a question.
Yes.
In Pakistan, we don't have IV thyroxine or levothyroxine. Can we give thyroxine tablets via NG?
You have a very logical answer. I'm not sure because
No, there is IV. There is IV also
there is
available in the
IV
market.
thyroxine is there.
Yes.
I don't
It
think
is
so. I
also
haven't found
available in
anywhere.
Pakistan.
I'm sorry. Yes, Dr. Asma, you were saying something.
I think IV thyroxine is available at Pakistan.
Okay.
In Karachi, maybe, but not in Islamabad.
Yes, in Karachi
No,
or
available also. I know in Sialkot also. I remember one patient we give IV, but
yes,
we
yes,
did the monitoring with the
IV
ECG.
thyroxine. Yes, sir. IV thyroxine is available at here.
Okay. Okay. So, what
Sorry, sir.
about
What
the?
about the,
Yes, yes.
what about the dose at the time of emergency? Can we insert at the bolus dose? There's like the 50 milligram or just more than 50 milligram.
Actually, I'm not. You see, remember one thing. You see,
No, I remember. What I remember, they give very small doses. They give 12.
Yes, sir. Mics in mics, I
IV.
guess 250 mics,
Yes.
but it is there are two forms. One is levothyroxine and one is thyroxine. I think the levothyroxine we give in mics, 250 mics or 300 mics.
yes, you see there. I have just opened it, and you can see here, 100 microgram per 5 ml single vial dose, uncorrected.
Levothyroxine dose is 200 to 400 micrograms in case of hypothyroid combo.
Yes, in
Yes,
levo
50
levo has
microgram
in
to 100
mics.
microgram. Okay, intravenously daily until the patient can tolerate oral therapy. Loading dose is 300 to 500. Okay.
Okay, sir. Thank you.
Yes. Actually, remember one thing. Your best friend in 2022 is not your Saheli. It is Google. Google is your best friend. Okay. So whenever you face any problem, Google Bacha, Google King, Google Uncle, whatever you say, will help you. Okay. So similarly, the question related to this, you prepared the patient. Like in addition to everything you will be doing, in addition to standard 1, standard 2 monitoring, you can say about intra-arterial blood pressure monitoring. Okay, especially if you are suspecting a patient with thyroid crisis. Okay, so this is one thing. And how to control this if uncontrolled, like undiagnosed pheochromocytoma or anticipated problems while you are doing adrenal surgery. So what will be the way to tell that? In addition to standard 1, the same one you will use, standard 1 and standard 2, you will be having intra-arterial blood pressure monitoring, CVP, and cardiac output monitoring if possible. Okay, and then you should have separate ports for both vasodilators and vasoconstrictors. Okay, you will have both vasodilators and vasopressors, because especially if you have undergoing this surgery, adrenalectomy. Okay, so after removal, this patient might go in severe hypotension. What else? Hypoglycemia. Okay, hypovolemia. So you have to anticipate and manage. What vasodilators you use? Phentolamine.
Hemorrhage as well. Bleeding diastasis.
I'm sorry. Okay, phentolamine. Sodium nitrate.
Yes, in intraoperative we can use phentolamine. We can use nitroprusside and nitrates also. And if there is tachycardia, we can add other beta blockers also. But first we also think about this.
What about
alpha
labetalol?
blockers also?
Labetalol
also increment dose.
So we can also use the magnesium sulfate, GTN, nitrates, calcium channel blockers, beta blockers. All
magnesium
are these
sulfate. What about lidocaine?
Yes, sir.
Lidocaine infusion.
Yes, Yes, sir.
It is membrane
Yes,
stabilization.
we can.
membrane stabilization and decrease the response,
This
both
is decrease
lidocaine
the
and
stress
magnesium
response,
sulfate.
both of them. Okay. And then you can have this dexmedetomidine infusion.
That's
Okay. What about epidural?
Yes, it
Also a
all.
good option
Yes, sir.
for the patient
Yes,
because
it's
it's
a
also
good one.
brother sympathetic stimulation.
Yes. Dr. Asma, you were saying something, please. What you are saying?
So epidural is very beneficial for post-operative pain or post-operative any crisis. So I think epidural
Yes,
is the best
epidural.
option.
Remember one thing, that just for information, that laparoscopic surgery, the role of epidural is relatively decreased. Okay, because in epidural you don't need such thing. Okay, because laparoscopic approach is a little bit different. For the incision is not that much big. So role of epidural, I'm not saying that it cannot be used, but the role of epidural has relatively decreased. Okay, erector spiny block is a very good alternative in these conditions. Erector spiny block, and because if they, according to the incision, this quadratus lumborum block. Okay. Of course, epidural is the mainstay, but also just have in your mind that if they are asking some other options, maybe they create this, they want to listen from you these things. Okay. And intraoperative, this use of lidocaine infusion. Okay. So because the main factor is to remove the stress. Okay. So you will have these things. So this is actually answer for intraoperative sudden hypertension as well, that you will be doing almost the same thing. You can use labetalol, you can use nitroprusside, you can use nitrates. Okay, you will preferably take intra-arterial blood pressure monitoring. You will use the correctable factors. You know, I should leave teaching, and I only should be concentrating on muting the people. This is not good. All of you are requested to mute. Okay. So I hope this is, I'm just trying to cover as many optimizations and management which are important. Okay, just a second. Okay. So if you have a patient at, we will be doing some simple things, just ulcer prophylaxis. You should be expecting, and you will be doing it. Similarly, aspiration prophylaxis, almost the same things. Okay, then you can anticipate about post-operative nausea, vomiting as well. What are the risk factors? There are patient factors, there are surgery factors, and there is anesthesia factors. Okay. So if you have more factors, like for example, female gender is a risk factor. Okay. A patient with the anesthesia, among the anesthesia, opioids is a risk factor. Opioid use of opioid. Hypovolemia is a risk factor. Similarly, if you have a surgery of middle ear, laparoscopic surgery, eye surgery, any surgery where this vagus bond is there, vagus nerve involvement, there is more chances. So you will be thinking about it, and then you will be managing accordingly. Okay. But what other optimizations you can have? There is very important topic of anticoagulants and antiepileptics. Sorry, antiplatelets. Antiepileptics, I'm saying. I will not go very complicated. I will tell you very simple things. Okay. Usually, what are the anticoagulants? Common anticoagulants, whether it is low molecular weight heparins, or if there is
Unfractioned.
heparins.
Unfractionated
Okay?
heparin.
So for this thing, you have either it is therapeutic or prophylactic. So 12 hours
Prophylactic.
to 24 hours for prophylactic or therapeutic. You have to stop it before. Okay, for unfractionated heparin, 4 to 6 hours. And even if it is infusion, you can stop 4 to 6 hours, and you can, because for this thing you cannot do anything. For unfractionated heparin, you can do ACT. Okay, you can do ACT or you can do ROTM to see whether its effect is finished or not. Okay, there is a test in it in Heptam. You can specifically do it. Okay, what else? Similar is that if you have to place epidural or spinal, similarly. So actually with low molecular weight heparins, epidural is not, with epidural, low molecular weight heparin is not recommended. Okay, when the catheters are, but usually we give it. So after placement, how many hours you can give low molecular weight heparin?
No, sir. Again, depends upon the prophylactic dose and therapeutic dose. Definitely, we will not give the therapeutic dose.
Of course.
But prophylactic dose, yes. After 2 hours after insertion of the catheter, we can use the prophylactic dose.
For both
Or
low molecular
if
weight
you want to
heparin and
insert,
2 to 4 hours,
yeah.
I think.
Yes, 2 to 4 hours.
And if you want to remove the patient, you started now. So after last dose, how many hours after that you can remove it?
12 hours after 12 last dose.
Yes, sir,
Therapeutic
after
dose,
12
of course,
hours.
you will not take it. Okay.
Yeah, well, prophylactic dose after 12 hours. And then now the next dose will be after 2 hours after removal of the catheter.
Yes. So Dr. Asma, you were saying something. I want everyone to participate. You were saying something, please repeat.
Removal of catheter after 12 hours, and after now we start the Clexi therapeutic dose after 2 hours of the removal of the epidural.
Yes, that's what Jamil said as well. Okay, so this is simple. So actually the problem is that sometimes you only don't rely on these guidelines. You have to see other risk factors. Okay, so if you have a patient at risk, you will always, you can, in the oral exam, it's very easy to say, always say risk versus benefit. Okay, this is your rescue answer. So what about antiplatelets and aspirin? You
Aspirin,
can
Continue.
yeah, we can
No problem.
continue
No
if,
problem.
until unless there is
Yes,
some
sir.
risk of
Aspirin
bleeding,
continues
like in spine surgery
preoperatively.
and craniotomy.
Yes,
sir,
again.
aspirin is always continuous preoperatively and postoperatively. You don't stop aspirin.
Okay, use the word can be continued. Remember one thing, there is difference between can be and should be. You don't need to say should be. Okay, you can say that you can continue. There is no recommendation to stop it, but still remember that in some patients undergoing closed cavity surgeries, you still,
like spine surgery and
yes,
craniotomy,
because
we have to
convention,
stop also.
our recommendation is like that, but practically if you use this word, that is more safe answer. Okay, that you can do it, but still don't my suggestion, don't use the word should be. Okay, then what about this clopidogrel or plus dual antiplatelet? 5 to 7 days. Okay, and why we need to stop it for 5 to 7 days?
They are irreversible, and the life of platelets also 5 to 7 days. That's what their new platelets will be appear then.
Okay, so this is and now, for example, if you have a patient on these medications and you have to undergo, either the patient is on actually I forgot to mention about warfarin. We will discuss about warfarin just shortly. If you have a patient on clopidogrel and you have to undergo a surgery, you will give platelets. Okay. And if you have a patient with warfarin, how
What
to manage?
about the bridging therapy? What about the bridging therapy?
Yes. I'm just start discussing this bridging therapy for warfarin. Okay. For bridging therapies for warfarin. So warfarin, what you do, five days before you stop it, and then day 2, what you do, you start heparin,
Lower molecular weight.
heparin.
Lower molecular mean heparin.
low
Peptic
molecular
dose.
weight heparin. Okay. And then 12 hours, 12 to 24 hours, whatever.
24 hours first we will
it
stop.
will be
Yes.
24 hours. Then you will start
Yes.
low unfractionated heparin. Okay. And then you will continue it, and 4 to 6 hours before you will stop it. And then you can reconfirm it with ACT. Yes, Dr. Asma, is this what you wanted to discuss or anything else?
Yes, sir, same as.
Okay. So again, I will repeat, 5 to 7 days before you will stop warfarin, and next day you will start low molecular weight heparin, and in this time you can do INR as well. Okay. So this one, and then you will there are 2 school of thought. Some people will start low molecular weight heparin, or some people will directly start unfractionated heparins. Okay. Because there is always a debate which is better, which is giving better results. So it is actually there is we discussed before, there is an anticoagulation team. Okay. Anticoagulation team, actually they are cardiologists. Okay. And their duty is to optimize these anticoagulants and antiplatelets. Okay. So this is how you have to approach these patients. So if you have a patient on warfarin and you have to undergo emergency surgery, what will you do? What are options for you? You can use FFPs. You can use
Prothrombin complex.
PCC. The first line be first PCC, then FFP.
Yes. You know, actually what PCC has, what is the complication of PCC?
Hypercoagulation.
It is
Yes.
it is associated with embolic phenomena. Remember one thing, this thing. Okay. And what is the problem related to FFPs?
Fluid overload.
Fluid overload and
Infections.
other side effects. Yes.
Infections. Okay. Fluid overload and infections. So you should have a concept. I hope you understand. This is a very important topic, and if you open the book, the
Vitamin
guidelines,
K also, sir. Vitamin K also, if we have a time, we can give 24 hours before surgery.
vitamin K, would you give IV or IM?
Both we can give, you know.
IM.
Depends
Yes.
on the time.
Usually it is given IM, but if you have a patient at risk, would you like to give IM?
No, IV is better. It's definitely oil based, but you know, if we give diluted IV, it's okay, acceptable.
No. It's not related to this thing. I was catching you.
I am, you know, there is risk of hematoma still risk of hematoma.
Yes. So this is the reason.
Bleeding.
Because if you are giving in a patient at risk of bleeding, if you give intramuscular injection, you are always intramuscular injections are controversial. Okay. So this is one thing. And how much time they need for the effect?
6 to 8 hours.
Yes, please. 24 to 48 hours. Am I right?
24 hours, sir. Yes.
Okay. So these are the things which you should be doing. Yesterday we discussed about bleeding patient. So this is all the consideration which we are included in that patient. Okay. So if someone has not listened, I will suggest you to listen. Okay. Okay. So if you have a patient on anti-epileptics, okay, anti-epileptics, or this, of course, this patient is epileptic. So how can you optimize? and what you will expect?
No, we can assess from the history how it is controlled, what is the last episode, and what is the drug he is taking, how much dose, and we can assess also the serum level of that
Drug
dose.
levels. Drug levels. Okay.
Drug
So
levels.
drug levels, and you are expecting to have liver dysfunction. Okay. Bone marrow suppression. Okay. Electrolyte imbalance in these patients. Okay. So you have to consider these things in the patient taking antiepileptics, and you have to monitor the drug levels. Okay. And another thing, what are the factors which can precipitate fits?
It's hypocapnia, stress, anxiety, infection, hypoxia, and
Hypoglycemia. Electrolyte
Hypoglycemia, you are
imbalance.
not telling. Hyponatremia, hypernatremia.
yes, electrolyte disbalance.
Okay. So, and then stress and
hypermagnesium.
I'm sorry. Yes, please again.
So decrease the level of magnesium. Also, the efforts
Magnesium.
करने के करवाते हैं.
Yes. What else? Anything else?
And some drugs, yes, the drugs which increases anesthetic drugs which cause epilepsis.
Like prolonged use of atracurium, ledonocene.
Enflurane,
Okay.
etomidate.
And florane. Actually, propofol also, you will be surprised to know that it decreases seizure threshold. It is used as anti-epileptic as well, but it can decrease the seizure threshold. So the best medication is thiopentone. What about
Also
ketamine?
avoid etomidate.
Ketamine.
Ketamine is also not recommended.
Etomidate.
So we have
Etomidate actually, as it is associated with myoclonus. Okay. But it can cause fits-like activity. So what else? What about cautery? Is it a risk factor or no?
I think no.
Sir,
It's
sir,
not
I
related
haven't
to
read.
central nervous
I
system.
haven't read
It's
anything.
only if neuromuscular disease or in dystonic patient, there might be a white cautery, but I think there is no role in epilepsy.
What about hypothermia?
Hypothermia.
It should be. It should be
Okay.
useful.
So
Indirect.
temperature less than 34. Temperature less than 34 is known as hypothermia.
Okay. No, I don't agree to your answer. Please try to correct it. Who speak this? Please repeat again.
सर 36 से नीचे हाइपोथर्मिया है माइल्ड, फिर 34 से 32 मॉडरेट है, फिर 32 से नीचे severe hypothermia.
Yes. So you just correct yourself, Asma. You said, or who said? Anyways, because it's mild, moderate, severe. You less than 34 is moderate hypothermia. Okay. So hypothermia.
There is one question here, sir.
Yes, please.
Sorry, sir, regarding the propofol. So propofol, regarding its use in ECT.
Okay.
As you said, it's decreasing the threshold. So
Actually,
is it?
You are absolutely right.
Is it,
Actually, you know, this may not be a clinical significant thing, but in MCQs, if you find a question like that, you can say that it itself can decrease seizure threshold. But practical clinical use, propofol is being used because in ECT you want something which is quick. Am I right? So in that regard, propofol is a good option.
Okay. So it's good for its.
Yes, it is good. It is good, but
fast effect.
Yeah, you know, thing is that if you are giving too much propofol itself, it is an anti-epileptic. It's used as so, but it is better to not to use thiopentone. Okay, because thiopentone is anti-epileptic.
not to use.
Yes, not to
Yes,
use.
for ECT.
So means
for
propofol
ECT.
is superiority.
We are talking
For
about
ECT, so
ECT.
propofol, yes. So propofol is superior.
Yes, yes. Of course, propofol is not only
Because
propofol.
in ECT, you want seizure to occur, not to suppress.
Yes. So thiopentone, if you are
Okay,
using
understood.
it can suppress it. And propofol for two reasons. Not only that it theoretically decreases the seizure threshold. This is number one. And number two, you want quick
Okay.
recovery as well. Okay. So this is the
Okay,
point.
thank you. Thank you.
So,
Great. Thank you so
yes.
much.
Okay, so I wrote a medication named Doxapram. It's not available in most part of the world actually, but it is available in some hospitals. You will be surprised that I was in King Faisal and I was very happy to see Doxapram because I had only read in the books. So one day I myself get. Do you know what is Doxapram?
This
No,
central
this is first
Is it
time.
a
and
respiratory
stimulator we
stimulant?
use. Yes.
Just a second. Who was saying? Please, one person.
Sir, it's a central stimulator, especially activating all the central nervous system.
So just a second.
Stimulant.
Just a second. Let
Resp-
Adnan speak. Yes, Adnan, what you are saying?
Sir, sorry, I read it about it is a respiratory stimulant.
Yes, it's a
Yes.
respiratory stimulant. Okay, so it's when you have given a patient naloxone, or if you have given flumezanil, okay, and the patient is still not waking up, okay, and respiratory depression is there, so you can try this Doxapram. It's a respiratory stimulant, but it's a CNS, generalized CNS stimulant, but so it can cause seizures. And by the way, once I give it,
that's I told that it's not, it stimulates the respiratory center mainly, but it's general stimulated. That's why it's cause fits also, because
Yes.
epilepsy we have to avoid in epileptic patient. It is contraindicated in ICP also, and patients have if a central mass or tumor, we have to avoid this Doxapram.
Yes. Okay. So just repeat that if you have a patient with epilepsy on anti-epileptics, so these are the things which should be in your mind. Okay. Among the anesthetic medications we have discussed, among the muscle relaxant we have discussed. What about tramadol,
Nitrous?
ketamine?
Pethidine also, yeah. Pethidine and trauma.
Tramadol should be avoided. Pethidine should be avoided.
I think nitrous also, I guess.
Nitrous, what will it's a simple thing. Nitrous is a laughing gas. It makes you laugh. Okay. I don't think so. Nitrous has anything to do with it. I doubt. I don't. Okay. Anyways, so now what thing was coming in my mind and just slipped out?
Tramadol, sir. You said tramadol.
Yes, tramadol. Yes. Just a second. I was saying something else.
Tramadol and regarding the hypothermia effect.
Yes. I'm sorry. I did not understand you what you were saying. Hyperthermia?
No, before you said hypothermia. So hypothermia should be
hypothermia, there will be shivering. Okay, so it can, number one, it can mimic, because it will have sympathetic stimulation. Okay.
Okay.
So maybe it's also acts as a factor to precipitate seizure. There you have to take, that's why you have to discuss with the neurologist, or discuss with that what factors trigger fits. Okay, there are
regardless. Sorry, boss. Regardless the effect, the severity of the hypothermia, because in some studies, especially in traumatic brain injury or this such conditions, sometimes
neurological outcome. Okay.
So this is not related.
Yes.
I don't think so. It is related. It
is related with the CMRO2 only, the temperature.
Yes, because the metabolic requirement is decreased. Okay, when you are a patient, either you are doing barbiturate coma, okay, or you are doing this therapeutic hypothermia. So it is reducing the oxygen requirement. So that's why the neurological outcome may be changed. Okay.
Okay.
So
Okay.
maybe it's not
Basically,
related to fits.
epilepsy or effects.
Okay. So then you have a patient on. Just a second. Just give me a hint. I'm just thinking and telling you.
Which hint, sir?
Any other topic? If you have a patient with allergy, allergic patient, what will you think?
Latex allergy?
Any allergy. In one of them is latex, one of them is antibiotic. Okay. In operation theater, with which medications are at this one muscle relaxant? Okay.
Muscle relaxants are notorious, yes.
Muscle relaxants. These are top things. 1, 2, 3 may be different in different studies, but you have to be careful about these things. Latex, antibiotic, muscle relaxant, and then histamine releasing drugs, which are
Atracurium,
tuberculin, atracurium,
some muscle
morphine,
relaxant like
morphine, tuberculin, morphine, histamine release, and what else? You can make a list of histamine releasing medications. Okay.
Pancronium, I think also.
Pancronium, yes. Actually, the only which does not
No,
is atracurium.
pancronium not. Pancronium release the histamine. No, it's vagolytic. That's no.
Just Jamil, only cis atracurium does not release. Rest, I think all of them can release histamine.
sir,
What about
those
Becoronium
steroid
then?
nucleus, sir, the steroid nucleus, they have a property
Becoronium also.
to release
Becoronium
histamine in
also
steroid.
does not
Yes,
release the
yes.
histamine.
No, I think it releases.
Pancronium also releases histamine,
Yes,
but it is famous
pancuronium,
for vagolytic.
vacuronium, and rocuronium. These 3 drugs, these
Even
have steroid
atracurium
nucleus.
also.
They
Atracurium
have a
also releases
steroid nucleus.
histamine.
They release histamine.
No, I don't
Atracurium
think so.
also.
It is related to steroid nucleus. Okay, because Vigronium and cis atracurium are related to least histamine release, I think. In the meantime, we are discussing. Just anyone just reconfirm it, okay? So that we don't waste time. Just reconfirm it about this point. And then what are the things which has latex? Your gloves.
Most of the time, these patients are medical staff, and second, they have other allergy from avocado, banana, and kiwi. Also,
Actually,
they have some.
Jamil, listen, because you are having a special relationship with me. So listen, you are not concentrating on the question. What question I have asked?
What is related with the latex allergy?
What equipment in war? What things are related to latex?
Okay. Sorry.
Okay.
Yeah, the equipments that containing the rubber means made of some totally with the latex, or some have some parts. In our day, before there was face mask, that was gloves before, just wearing gloves, and some surgical instruments also. Before there was some respiratory breathing circuits also were made of
gloves,
some.
Usually gloves,
Yes.
endotracheal tube, NG tube, Foley's. Okay, so these are the culprits in the operation theater. Okay, of course, the patients who have now we can say some patients who have fruit allergies. Okay, the patients who are
we don't give fruit in operation theater, so I think there should not be any problem.
Yes, but of course, spina bifida. Okay, patients with cerebral palsy, how they develop, the chances of this one.
No, dear, I just want to correct that. No, we are not giving the fruits. But if patient have allergy from avocado, kiwi, again, we have considered about the latex allergy.
You know,
definitely.
maybe we will ask the examiners to provide fruits to all the candidates. Okay. Yeah, you are right.
They will give
just-
fruits of patients only.
Yes. You know, on a lighter note, just to give you people a relaxing thing, you know, there is a special technique by anesthetists. This is called as banana strategy. Do you know about this banana
Yes,
strategy?
It was happen in my hospital. Anesthetist offered
No,
all
sir.
the patients banana, and then he canceled the list, because
Yes.
all they have.
They, in especially in some part of the world where we don't have proper holding area. Okay, so all the patients are sitting outside with the file in their hands, and suddenly a person came and offered all of them bananas. Okay, and actually this strategy is to cancel all the list. So all the patients will take banana and all the patient NPO will be finished. Okay. this is just a distracting.
The surgeon will kill that person who is distributing the
No,
banana.
the main crux is that the person who will distribute will be an unknown person. Okay, so there is no proof. For everything you need a proof. Okay, anyways, so allergic patients, especially these patient you have, and for those if it occurs, your approach is airway breathing, circulation, intramuscular or IV epinephrine. Okay, steroids, check send tryptase level, and actually it is serial 0 and 6 and 24 hours. Okay, and then when the patient is surviving, you will be giving a band, allergy band. Okay, and if for example that's just specifically, other than all these things, which is the most common like not common, which is associated with most incidence of anaphylaxis, muscle relaxant, you will be surprised, it's rocuronium.
Rocuronium, sir.
Okay, so actually there are studies to give Sugamedex. Okay, and it has a significant effect on the outcome. Okay, if you have Sugamedex when you are using rocuronium and you face this problem, you can immediately give Sugamedex. Okay, so airway breathing, circulation, epinephrine, steroids, nebulization with the salbutamol and ipratropium if there is.
Sorry, sir, what are the dose of epinephrine and anaphylaxis reaction?
Yes. You know, if it
let
is.
Let me say, it's
Yes.
depends upon it. It's most of the time commonly for route. There are two routes, IV and IM. If we give the IV, it's 1 to 2 mics per kg, and in adults roughly it's to give 100 to 150 microgram. But in adult, if we give the IV, it's 1 to 2 microgram per kg. But if the other route is intramuscular, for adult it's 0.5 milligram, that means 500 microgram subcutaneous or intramuscular. And for the pediatric,
No, just a
if there
second,
is no
Jamil.
IV line,
Intramuscular or subcutaneous? I think it is
subcutaneous is better.
No. It is intramuscular.
Intramuscular, okay.
Intramuscular. Okay. So actually in the recommendation, it is written intramuscular. You will be surprised. I don't believe it and I don't follow it. But actually in the recommendation, it is written intramuscular. And then you can give IV as well. So dose is like that. Okay. I hope you agree, Asma.
And in pediatric, 10 microgram per kg intramuscular.
Thank you, sir.
Yes. Okay. So this is actually good. And now we are discussing so many topics together. So what will be the signs, symptoms of anaphylaxis during anesthesia?
Hypotension, tachycardia.
Increase peak pressures.
Yes.
Just a second. Let Asma talk, please. She has. Whosoever wants to participate, just raise the hand. Maimuna, you are silent mode, I think, today.
You
Hello?
depress her
Sir, I'm
at the
just
start,
trying.
that's why.
I'm listening, sir. I'm here and also thinking somewhere else as well.
Okay. Yes, Asma, please tell.
Sir, hypotension, tachycardia, urticaria, and rashes are all over the body. This is the clinical signs. And about the ventilator, the high peak pressure, bronchospasm.
Okay. What else? Actually, I will tell you something. As some voice came regarding airway pressures, because this hypotension, tachycardia may be masked during anesthesia. Okay. And rash, the patient will be covered, so you may not be able to pick it. So the most, I think you are, if you they ask you this question, and under the anesthesia in ventilated patient, peak airway pressure rise may be the first sign.
Yes.
And
Yes.
if maybe hemodynamic collapse. Okay. Because this hypotension and tachycardia is maybe non-specific. Okay. Why non-specific? That maybe you are it can be because of anesthesia drugs as well. Okay. So airway pressures without any reason, if suddenly, and actually I forgot to mention about blood transfusion reactions. Okay. So this is also one of the cause for allergy, like hypersensitivity reaction. Okay. As we discuss about latex and antibiotics and muscle relaxant. Okay. And among all these things, we forgot to tell one thing, that you have to stop the trigger. Nobody mentioned it. Stop, call for help. Stop surgeon. Okay. So what is the next? Okay. So if you have a patient in which the surgeon said to you that don't give muscle relaxant because I have to do either neuromonitoring or nerve monitoring. First of all, what will be those conditions in which you have to do like that?
Sir, in spine surgeries.
Total thyroidectomy, spine surgery,
Scoliosis surgery.
and
Scoliosis.
awake craniotomy also. There also, you know.
Parotid surgery, if the surgeon wants to preserve facial nerve.
Parotid. Okay. What else?
Parotid mastoid surgery.
What about
Thyroid also.
hearing aid?
Mastoid.
What about
Mastoid.
cochlear
Cochlear
implant?
implant.
Cochlear implant. Okay.
Implantoplasty. Yes.
Mastodectomy as well.
Mastoidectomy. Not tympanoplasty, Jamil.
Yes, I was about to say not tympanoplasty.
No,
We
not
give,
tympanoplasty.
Sorry.
Mastoidectomy. What
Yes.
else?
There we give a hypotension.
Thyroidectomy.
Yes, hypotension.
Thyroidectomy. Yes, thyroidectomy. Okay. So you can make a list. Okay. I'm just giving you a hint that awake craniotomy also, and in any neurosurgery in which they are doing the evoke potentials. Okay. So they are doing the evoke potential neuromonitoring. Also in scoliosis, as we discussed. So what will you do now? So there are certain things in addition to standard 1, standard 2 monitoring, you are doing BIS actually, which is BIS or entropy, which you are doing from anesthesia side. This is one thing. Then there is actually in the majority of hospitals where there is a department, neurophysiologist, so who is taking care of it. And there are certain rules for it. If you are monitoring the evoke potential, maybe you even don't have to use inhalational. Okay. Maybe even
Tiva.
Yes.
Tiva is
Sorry
good.
for interruption. Yes, a little bit about entropy, you know. You can.
okay, is a dimensionless processed EEG, dimensionless number, okay, and it is a result of processed EEG, and there is level of in the anesthesia you are targeting 40 to 60 number, and
No.
number
What
increasing is
it's in
wakefulness.
BIS. It's BIS, but what is the difference between BIS and entropy?
This is just like difference between ROTAM and TAG.
No, sir, there is a small difference I've read somewhere. I think in entropy, there is some abnormality that we detect.
Okay, I have no idea about it. Okay.
Yeah, the BIS definitely I know about the above the 80. It's a
Actually,
it's a
Jamil,
dissolution.
Let me see.
yeah, just have a look at it because we have to cover a number
It's
of
written
topics.
in Masterpass, I think, or podcast. I've read somewhere.
You can just tell about it. Anyways, so the options we have is to do the BIS. Okay. You have to avoid even inhalational at times. You have to do TIVA and TCI. TIVA is total intravenous anesthesia, and there are specialized pumps by which you are giving target control infusion. Target. This is by
Like in
pump.
propofol.
There is this is for propofol, remifentanil, and fentanyl. Okay, and
we can go some with detail about Marsh and Snyder's. No.
Marsh model and Schneider model. Actually, remember one thing, because there are
They can ask in the exam, sir. No,
they can.
TCI, no.
Jamil,
No.
actually, they can ask. Okay, TIVA and TCI, they can ask. Just let me please finish this topic. I will tell you the important things, that actually what is the theme of it is they put the demographic data, age, sex, height, okay, and then there is a specific model in which they will the purpose is to have a bolus dose, okay, and a maintenance dose to maintain drug levels in the blood, okay, and they work on this 3-compartment model. Okay, there are a lot of limitations for this TCI, and the purpose is that, for example, if you because why it is a problem here, that the neurophysiology, if you are giving not giving a steady state level, okay, the problem is that maybe that will be interfering with the monitoring. Okay, like you give a bolus, suddenly maybe there is depressed EEG or depressed evoke potentials. So they cannot detect whether they are entering in the wrong place or it is because of anesthesia. So actually the purpose is to maintain a drug level in the blood. Okay, so this is
I found a difference between entropy and this. It's written entropy monitoring for depth of anesthesia relies on assesses the degree of irregularity in the EEG signals.
okay.
So basically it assesses the degree of irregularities in EEG signals.
Okay, and what about BIS?
This is just a processed EEG.
Processed EEG. Okay.
Yes, it was a confusion for me about the entropy. Thank you very much, Dr. Hassan.
In evoke potentials, there are sensory evoke potential, motor evoke potential, auditory evoke potentials. Okay, so they are checking the integrity of the sensory system, sensory tract, and motor tract. What is the main sensory tract and motor tract? Motor tract is dorsal column. Sorry, corticospinal tract. Sensory is dorsal column. Okay, and motor is corticospinal. Okay, so in these patients in which they have to do the neuromonitoring, you will be avoiding inhalation agents. You are using preferably Tiva with propofol, remifentanil, if it is available, fentanyl or dexmedetomidine. Okay, they use it for to avoid muscle relaxants and avoid inhalational agents, because they change, remember these words, amplitude and latency.
Latency.
Okay, latency is the time of the, like, if you give a stimulus and after how much time the response is coming. Okay, this is latency, and how much response is occurring is amplitude. Okay, you give a stimulus and after 5 minutes, for example, there is some response, and the response is, for example, 10. So the if anesthesia is not only delaying this 5 minutes to 7 minutes, for example, and amplitude, if the maximum amplitude is 10, now with anesthesia it is going down to 5, for example, so the amplitude is decreased. So latency is the time.
The amplitude is the frequency.
Okay. No, amplitude is not the frequency.
It represents the frequency.
No. Amplitude is the
Amplitude is the height of the wave. Basically,
height
in
of the wave.
waveform it is being, yes, it is in waves. It is represented on screen.
I will tell you in a funny style that if someone is irritating you, after how much time you slap, okay, this is latency, and how bigger slap you give, this is amplitude.
Amplitude, right?
Okay.
You are confusing, Mr. Nadeem, wavelength with the frequency.
Yes, amplitude is different thing. Wavelength is number. Okay. Okay. So these are words, and actually in the even in the facial nerve or during thyroidectomy, they are monitoring the recurrent laryngeal nerve. Actually, for recurrent laryngeal nerve, other than this direct stimulation, there is a special endotracheal tube, okay, which has electrodes implanted, and they will place it, and then they can check via the movement of the vocal cords. They do it with the thyroid in the thyroid surgery, when they are monitoring the recurrent laryngeal nerve. Similarly with the facial nerve, as in occurring in parotid surgery or in mastectomy, they are doing it. So the purpose of is that if you have given muscle relaxant, so that there will be no response. So they don't want, even if you have, you can give the intubating dose, and either you can reverse with reversal agent or Sugamedex, or you have given a dose and after a certain time you can check with nerve stimulator that the effect of neuromuscular blocking agent is already finished. So in that time you have to monitor like that. Okay. So now just a second. You have a patient with tourniquet. I'm just trying to wrap up. We have taken a lot of time. What are the problems related to tourniquet? What can occur in tourniquet when they are doing the tourniquet? What complication can occur? Let me ask someone else. This one, Asma, please. What are the things related to tourniquet?
Sir, when you apply tourniquet, have ischemia or maybe any infection. It is very important for time related and how much prolonged surgery. So first we consult with the surgeons and update timings, 1.5 hours or 2 hours. So I think according to that.
Okay, so I will just tell you that when they do put the tourniquet, at that time, if for example, specifically if you are talking about fractures, okay, because usually they are doing it for decreasing the blood loss at that time. So actually embolism can occur. Fat embolism can occur at that time. Fat embolism or thromboembolism can occur that time, and they are putting it, especially if they are doing Esch mark. So this is the thing which they are doing at that time. And then when they inflate, at that time there is autotransfusion. Okay, there is autotransfusion, extra mils, which may not be significant in some people, But if a patient is already having limited cardiac reserve, patient can collapse. Okay, so this is another thing. Then the pressure, how much pressure they are giving. So the pressure related, there will be ischemic pain, there will be any nerve injury when they are putting it, and of course, as much time will increase, as much ischemia can increase. Okay, and similarly, when they open it, the debris and the ischemic inflammatory mediators can go, and it can cause hypotension. Okay, and similarly, there is redistribution of fluid, so the patient can go in hypotension. Okay, got it?
Thank you, sir.
And tourniquet pain is an important concern, and it's mediated by I'm writing protein C, whatever, this C-type fibers. Okay, C-type fibers. And what are the ways to do it? Is to reduce, of course, one of the option is ketamine. What else can be given for tourniquet pain? Yes, Jamil. Tourniquet pain.
Under GA, just will give some doses of the ketamine, and if spinal, then I think it's already now it's volunteered in spinal. What do you think?
I don't think so. That
Only deepen the anesthesia. I think the option left. We have.
Yes. Any other option, Usman? Usman is here, left
I
already.
think the depth of anesthesia is important.
No, actually, this is related to C fibers, and actually, sometimes it is difficult to control. Okay, even during general anesthesia, if you have a tourniquet and the patient is going tachycardic, other than that, you have given analgesia, still patient is tachycardic. This is related to tourniquet pain. Okay, so remember, no need for beta blocker. You will try to deflate. Okay. Okay, so
Sir, sorry, some few words about scoliosis surgery or respiratory lung disease. There is somehow we can optimize that patient.
I will just come to it. Just give me a second. The same thing which occur in tourniquet, similar, almost not exactly like that. The same thing occur in cross clamping. Okay, and release during aortic surgery. Of course, the gravity will be more, but it is almost at the same effect. Okay, so you are asking about scoliosis. Actually, scoliosis, it will be dependent on whether it is juvenile or related to any fracture, related to any neuromuscular disease. Okay, so if you are talking about restrictive lung disease, it will be resulting in pulmonary hypertension. Okay, so they are using pulmonary vasodilators like this sildenafil. Okay, what else are you talking?
The pre-operative, if the patient comes, then definitely we have to do the PFTs.
Of course.
With the, yes,
yes, and you can see there are you can do some incentive spirometry.
Yes, and the balloon inflation. Sometimes then advise to
it
just
is the same it is the same incentive spirometry.
Yes.
Chest physiotherapy.
Chest physiotherapy.
Yes.
And if there is any infection, you will treat it. Okay. So these are the things. If it is related to pulmonary hypertension, you will treat pulmonary hypertension. If it is related to infectious things, you will do like that. Okay. So patient with pacemaker.
Any word about Cobb's angle, sir? I
No.
confuse it between what cable is it's lateral side or inside the spine. If we see the
Sorry.
graphically, can you explain? Yeah, it's like this vertebra,
Hmm.
and
I think this angle.
Yeah.
Am I right?
Yeah.
Okay. So patient with pacemaker. What are things need to be optimized, and what are the care intraoperatively?
patient with sir
Pacemaker.
pacemaker. First of all, we just rule out what was the indication of the pacemaker,
Indication.
and yeah, and what
Response.
type of pacemaker response, and
Okay.
when it was last time checked by the cardiologist or electrophysiologist.
Yes.
About
Cardiologist.
the battery stress, yes.
And
So first of
any
all, type of pacemaker, temporary pacemaker and permanent pacemaker, and temporary pacemaker, the single pacing or dual pacing.
okay. Actually, Dr. Asma, thing is that when we are talking about pacemaker, it is usually 99% cases we are supposed to it is AICD. Okay.
Okay,
If they are
sir.
asking you in the exam, this is actually AICD. So type related to this one is that what type, whether it is the simple pacemaker, and usually nowadays this is automated internal cardioverter defibrillator, because it has not only pacemaker function, it has defibrillator function. Okay. So
Okay, sir.
it has both functions. So what was the reason, and now is there any patient symptomatic, and like any palpitation now it is occurring. Okay. And then any local bruising or any like hematoma formation or anything like that. Okay. And then you can confirm it via ECG. You can see pacing wave, pacing. You will see now what you said, pacing
Spikes.
pacing spikes. You will see. Okay, and in echo you can see the any failure, or you can see the leads. And then similarly X-ray, chest X-ray. Okay. And then another thing is that all the things which can change the pacemaker threshold. So it will be electrolytes or anything like that. Okay. And then though two things you have to see, do a defibrillator function, you have to switch off. Okay. And now how to tackle it? You will attach defibrillator pads. Okay. Defibrillator pads you will attach, and pacemaker you will make it on fixed mode. Whatever mode it was, you will just make it at a fixed mode. Okay. And you will try to avoid diathermy. If you have to use it, you will try to use it bipolar. Okay. Or you will use it in short bursts. Okay. You will find in the YouTube recordings I had discussed in detail. Actually, this is a quick revision. I'm just trying to revise as many topics which may be asked in the exam in quick time as possible. Okay. Each of the majority of topics like pacemaker, we have discussed in too much detail, around 1 hour session only on pacemakers. So you can have a look, and then you will avoiding all the factors which can change this pacemaker threshold. Okay. And you cannot take the patient to MRI. Okay. I think we have covered a number of topics. Now, Jamil, you tell about MRI, patient for MRI.
Yes, sir. Our anesthesia concern about that it's a remote area. First of all, yes, away from the main OR. If we call for help, it will be
Reason
delay.
for MRI is very important.
The MRI, yes, reason for MRI, most of the patient is old age or very
Young
maybe
age,
small
babies,
yeah.
babies for diagnosis of
also,
any
yes.
neurological problem or
Extreme
any,
of yes.
and
Extreme
actually
of age.
these patients are usually claustrophobic. Okay.
Yes, they have
So
some neurological disease also.
they may have. Okay. So they
Related
may
to this.
have for any neuromuscular problem, which are like unusual problems you can face in these patients. So, and then there will be things related to the MRI machine. So what things you will be telling
Equipments,
about
yes.
equipment? What will be the problem that
MRIs, there is first of
strong
all
magnetic field?
magnetic field there.
Okay.
Very
So you
cold.
need
This is called
special,
hypothermia.
very cold hypothermia. What else? There is, if you are talking about
Noise.
environment, noise, so much
Noise,
noise,
yes.
noise
Yes.
and risk of hypoxia. How?
This quenching, due to quenching, there is some reason of
Actually, if it is malfunctioning, there is sudden release of very large amount of helium. Okay. So there should be oxygen sensor in MRI suit. And for
yes.
noise,
It's called
they cover
quenching, yes.
the ears. Okay. And this very cold environment, because the MRI machine, they have to keep it cold for its maintenance. Okay. And then all equipment should be MRI compatible.
Are safe. There is still no other terminology. MRI safe, compatible, and unsafe.
They can ask you about the gauze lines. I cannot recall. You can read about them.
Yes,
Okay?
gas line, there is lag time between detection of the CO2.
Yes. And for example, if you are
And
only
poor access,
giving, if you
poor
are
access to
only,
the patient
yes,
also.
if you are only giving conscious, deep sedation, okay, you have to make sure that you are able to monitor the oxygen saturation and, if possible, and tidal. It's not very easy, but if you are not maintaining the this one airway, then these are the problem. And the endotracheal tube, even, you know, there is a cuff, and the cuff, there is a spring. So this can also create a problem. So you should have an MRI compatible. If you put a normal pulse oximeter, there may be burns. There are incidents of burns during MRI. Okay. And of course, it will be out of OR. There will be limited access. There will be limited manpower, unfamiliar environment. So these are the things which when they are asking about MRI, just try to start from the patient related problems, and then the environment related hypothermia, noise, hypoxia, and things like that. Okay. And then the compatibility issue. Okay. So I think we will stop here now, and thank you very much for your presence. Any question, any of you want any question at any time, you're all welcome. The recordings are there in the this one YouTube. Whatever I discuss, all of them are there in the playlist. If you want to ask any question, you all are welcome. I suggest you to change your approach to study. Believe me, if the residents, some of the residents, they say that this is very difficult, or how the knowledge is too much. No, I don't believe that number of things which I'm discussing. I don't think so. There's anyone who will say that I have not read or studied or seen anything before in my life. It's not possible. All of you, even first year resident, you have passed FCPS part 1, for example, or whatever. So don't underestimate yourself. Okay. Dr. Saima, are you, if you can speak out, are you from YouTube? Sorry, are you from WhatsApp, or are you getting this link for the Zoom meeting from Facebook? Just if you want to note down my number and message me. So you don't know about YouTube channel, which WhatsApp group you are on? because I share I share the link for YouTube channel every nowadays. Okay, so it is okay. So this is my number, and anyone can contact me anytime. And this one YouTube channel link is there. You can find all the recordings whichever I have done. If anything you don't understand, you can ask anytime. Okay. And my message is that the best way to learn is to teach. I repeat, the best way to learn is to teach. Even if you have small knowledge, please share it to other. The best response will be that you will never forget. Okay. So thank you very much. And any questions? Okay. Thank you very much. See you tomorrow, inshallah. Same time.